The following audio-supported podcast is intended for informational and educational purposes only and is not intended as medical advice. Please speak with your healthcare professional before making any treatment decisions. The guests on today's show were paid to participate in this podcast.
What's up, Cheat Codes listeners? It's me, Dr. Z.
And me, Dr. C.
Dr. C, how are you doing?
I'm doing good, Dr. Z. How are you doing?
I'm doing really well. I think it's really fun that we get to do this live in person. I'm happy to be in Detroit. I'm happy to be here with you.
I'm excited about it, too.
We've done these Rising Star series, and we've had a few of them. We fell off a little bit with that series, but I'm really happy about the guest we have today.
I am, too. Our own homegrown rising star.
Yeah, it's pretty cool. So for the Cheat Codes listeners, hang on just a minute. We're going to grab our guest, and we'll be back.
Let's do it.
Let's do it. Cheat Codes listeners, with us today, we've got Dr. Alex Glaros, a rising star in sickle cell disease. Dr. Glaros, welcome to Cheat Codes.
Thank you so much. It's a pleasure to be here. It's good to see you guys again.
Yeah, it's good to see you, too.
You know, we've known each other quite some time, and we're going to get into the story a little bit, but tell us a little bit about yourself.
So I'm just a Midwest guy. I grew up near Detroit in a little suburb north of Detroit. Came from a family of nurses, so I'm the black sheep by being a physician. My parents are nurses, my wife's a nurse, all my aunts are nurses. It was a little bit inevitable that I was going to go into medicine, and I kind of always wanted to stick around Detroit. I love Detroit, and as I progressed through my education and everything, I met good people that eventually led me into sickle cell disease.
U of D high guy.
U of D Jesuit, that's right, go Cubs.
Very cool. The first time, Dr. Callahan, I don't know if you know this story even, the first time I met Dr. Glaros was on his trail for residency interviews. I met him at a recruiting dinner. I'm pretty sure we were at an Andiamo's.
Andiamo Royal Oak, yeah.
And that was the first time I got to meet Dr. Alex Glaros in real life.
I remember you telling me there's a star at Beaumont who wants to do hemonc, and we got to get him over here.
So talk me through that. You go through, obviously, you train here as far as high school. Where's college?
So I went to college right up the road at University of Michigan.
Mm-hmm.
Go Blue, we finally have something to cheer for in Ann Arbor. And then I went to the University of Toledo, College of Medicine for medical school, still an hour away. So I was driving back here all the time to see my then fiance that I met at Michigan. Kind of wanted to stick in the area, so I ranked Beaumont very highly. I ended up at pediatrics residency at Beaumont in Royal Oak, where I met you, Dr. Z, and where I actually was a co-resident in my year with Dr. Z's wife, who's also a physician. Right. And I just latched onto him and started following him everywhere. So
let's back up just a little bit and tell me a little bit about why pediatrics. What drove you into sort of that aspect of medicine?
Pediatrics, I always was drawn into in some form or fashion. I knew I wanted to work with kids, whether it was in education or in medicine or some aspect I wanted to work with kids. And I was just drawn to the idea of molding young minds. But, I felt like the impact you could potentially have was really big because you impact someone at an early age, and what is that person going to go on to do? And you're sort of, at the base of a tree, and it spreads out in any number of different directions. And that really was what drew me to it. I just wanted to make a difference, to put it simply in the old cliche. And then when I went to medical school, I actually was leaning more towards the surgery side, pediatric surgery. I wanted to take care of really sick kids. And I found myself, as I was rotating through pediatric surgery, enjoying the clinic and the follow-up visits a lot more than actually being in the OR.
Yeah.
And they say that's a first branch point in medical school, and knowing what you want to do is, do you like being in the OR? Do you like being in the clinic? Yeah. And I definitely was more clinic. I wanted to talk to patients. I wanted to get to know them. And so that's what led me to pediatrics.
That's awesome. And then your exposure then through pediatrics, you got a little bit of hematology during your residency, right?
A little bit, yeah. It's honestly mostly oncology. Beaumont is a very different setup than Children's Hospital in Michigan, where I did fellowship and I worked with you guys. It's a smaller setup, and it's primarily oncology and more benign hematology, acute hematology issues, less so than chronic diseases. I really was drawn into that because, again, I had this attraction to taking care of sicker patients. And hemonc, a lot of people say, is a nice combination of those two things. Really sick patients, but you get a lot of continuity of care. You get to know the families, you get to know the kids.
Absolutely.
I think it was a perfect fit for what I was looking for.
Any exposure to sickle cell in your residency that you memorably had, or did that just come later on in your training?
Really later on. I think I took care of maybe 3 patients with sickle cell. 3 encounters the entire time I was in residency.
Wow.
They came in for pain crisis, and we had very good hematologists there, but you just don't get that much training. Really, anywhere outside of major sickle cell centers, you don't get a lot of training in sickle cell. I grew up, as I said, in Royal Oak. I went 26 years really without knowing anything about sickle cell. I didn't know that there were 3,000 patients in the Detroit area with sickle cell.
Right.
And I went through residency. I learned they have some pain, and we hopefully can get them out in a few days. And I didn't really learn the underlying pathophysiology that. It wasn't until I went to fellowship down here in Detroit, that I really learned what that disease meant, and what it meant to patients, and ultimately what it would mean to me in my career and in my life.
Agios is a biopharmaceutical company that's fueled by connections with patient communities, healthcare professionals, patients, and each other. Building on these connections and the company's unmatched leadership in the field of cellular metabolism, Agios is pioneering therapies of genetically defined diseases, a broad group of rare and more common diseases that are typically severe and life-threatening. Near term, Agios is focusing on hemolytic and acquired anemias, including sickle cell disease, pyruvate kinase or PK deficiency, and thalassemia. To learn more, visit agios.com. That's agios.com.
When was that moment that you realized I'm a sickle cell doctor, and what was behind that?
Yeah, I think I tell this story a lot. And I was in my first year of fellowship. So first year of HEMONC fellowship, you really are doing the bulk of your clinical rotations, right? And of course, in Detroit, we have a very high volume of sickle cell warriors coming through the hospital every day. We take care of them on the inpatient side. We take care of them in the clinic. So, I just started to be introduced to how bad can this pain be? What are the other complications of sickle cell disease, which are innumerable, right? And I just started to realize that we're managing pain in a way that is really just putting a Band-Aid on it. And patients are in the hospital for too long. They're in the hospital too frequently. And there's not a whole lot of options for managing that pain. And then as I dive more deeply into it, I learned there's not really a lot of options for managing anything. Because when I started my fellowship, there really was hydroxyurea, and that was about it. I think one day I was rounding with Dr. Z, and he said, we manage these patients with morphine. Sometimes we'll use lidocaine patches. Sometimes we use a lot of Toradol. We try various things just to almost throw it at the wall and see if it sticks. And he said, why don't you look into some topical pain therapies, topical analgesics, because we were using lidocaine patches fairly frequently. And so I just started reading. And I started reading about lidocaine, ketoprofen, capsaicin, all these different analgesics. And I'm thinking any one of these could be a game changer for sickle cell disease, but nobody's investigating it. Nobody's comprehensively looking at these. And we're just trial and error and guessing. And so I think I might have just started writing up a protocol and for a study looking at capsaicin. And I came back to Dr. Z, and I think you were probably at that meeting too, Dr. Callahan. And I showed you guys the protocol, and Dr. Z just said, I got big plans for you. From there, I was just all in on sickle cell. And it really was just the need, I think. There's such a need.
There's a couple things in your story that are, I think, really interesting. The first is your residency was 12 miles away from Detroit, and you've got a center where you've got 2,000-3,000 people with sickle cell disease getting care, and you're literally 12-15 miles away, and you had 3 encounters, right? I think that's such an important thing in sickle cell that really is important for warriors to hear, in that not every doctor you run into is going to have necessarily that level of familiarity or comfort with sickle cell disease, right? You may be in a big metropolitan area, but really it takes for people to be at dedicated sickle cell centers where they're really getting those people who have familiarity with that disease. I think that comes through really nicely in your story. Secondly, I remember that meeting very well, telling you that I had big plans for you, and it turns out it was a pretty good bet to make. Exceptionally busy, doing a lot of things right now. You are running one of the premier sickle cell centers in the country here in Detroit. You are obviously working with capsaicin. Tell us a little bit about the role you're in currently. Tell us more about the capsaicin therapy, what you've learned about it, and tell us a little bit about what your plans are here in Detroit, what you're trying to build.
So right now I'm serving as the medical director for the Comprehensive Sickle Cell Center at Children's Hospital in Michigan.
It turns out we know the guy that used to have that job.
We do. I took that over when Dr. Mike Callahan left. So it's big shoes to fill.
I think the program stepped up quite a bit.
I don't know about that. Before that, it was Dr. Ingrid Sarnak, and it was Wanda Sherney, and it was Charles Witten. And so there's really titans of the sickle cell field that have been in Detroit. So I really take that to heart, and I want to continue that legacy of really committing myself to improving the lives of warriors in Detroit and making this truly a center of excellence beyond even what it is, because what we thought of as a center of excellence 10, 15 years ago is different than what we thought it was 5 years ago, and 5 years from now it's going to be totally different. Science is changing so much. Availability of disease-modifying therapies is changing so much. And so what that means to me is making this a center of excellence is bringing therapies to patients and making it as easy as possible for them to access them. And that means therapies in the pipeline, that means approved therapies, and that means therapies that are approved for other diseases that might also help them in sickle cell disease, and removing all the barriers for them to access those therapies. So my main efforts at Children's are to continue on the legacy of clinical trials and research that both of you started there, or not started, but I think ramped up there while you were there, and do my own research and also have as many services as possible in the clinic. And so one of the areas where I've tried to do that is bringing TCDs or transcranial Dopplers into the clinic, because previously what we did is send patients to the radiology department. There's scheduling issues. They have to come back for another visit.
For the warriors who may not know, tell us why that's important. What is a transcranial Doppler and why do you need that?
Yeah, so transcranial Doppler is an ultrasound that looks at the speed of the blood flowing to your brain. And 20, almost 30 years ago, we learned that if the speed of the blood going to your brain is elevated, that indicates there could very well be narrowing of the blood vessels, which means you're at a very high risk of stroke. And if we find that there's a high risk of stroke, then we can actually intervene, whether it's with blood transfusions or hydroxyurea, and prevent a stroke.
Yep.
And stroke is debilitating. You can lose function of limbs. You can lose cognitive ability. Worst case scenario, you could die from a stroke. So this screening test is supposed to be done every year, but throughout the country, the number of people actually getting this test done falls well short of what it should be. And there's a variety of reasons for that, but what I wanted to do is basically eliminate all the barriers on the patient end. And that means if you come to our clinic for a regular visit, you're going to get a TCD.
It's such a beautiful thing, man. It's such a simple thing, but it's such a beautiful thing. I love that.
It sounds simple. You just take the ultrasound and bring it to where the patients are and make it so you don't have to schedule an extra appointment and come back and have your appointment canceled or all the things that can happen. But I imagine it wasn't easy to do.
Probably a lot of fighting.
Yeah.
A lot of advocating.
It's, the health system is very set in its ways, right? And changing, this is really a system change. And when we went to, now a lot of people in our hospital system are on board, but when we initially went to the radiology department and we said, hey, what do you guys think about coming up to do the studies in our clinic? They said, why? We do tons of studies down here.
Yeah.
I said, no, we have 800 sickle cell patients. Probably a half to 2/3 of those this is an indicated test every year. And we're 50% at best of the studies that are supposed to be done are getting done.
Yeah.
And they said, we had no idea. They just come to us and we do them. It's not their fault necessarily. It's just a system problem.
Absolutely.
And so after I told them that, they said, oh my gosh, yeah, definitely. We should try this. And so we piloted the program. The radiology department was sending people to our clinic. But then it became a resource issue, right? Because we're pulling machines away from other areas. We're pulling techs away from other areas.
Sure.
And so then I started to seek grant funding to improve the availability of machines and techs. And so we actually recently were awarded a grant from Michigan Department of Health and Human Services to develop this program.
Amazing. Congratulations.
Thank you. Thank you. And so we're very excited. I think it's going to be a game changer.
Totally agree.
Another thing I've seen since we left is something we always wanted to do, a transition program. But one big barrier to that was we didn't have people to transition them to. And I feel you've worked with other partners, adult treaters in the area, the Sickle Cell Disease Association, and now there is an adult center and there is a transition program, which I think is another great step for the patients in Detroit. Tell us about that a little bit. How did you get involved in that and what's the state of it now?
Yeah, so transition is a hot topic in the sickle cell world, right? It's sort of a hot topic for all chronic disease, right? Because we do a really good job in pediatrics of taking care of chronic diseases. That's why adults have chronic diseases now, right? Like sickle cell disease, if you go back 30, 40 years, patients weren't living out of their childhood. They were dying of strokes, of infections, of acute chest syndrome. And so even though that's a long time ago, the infrastructure hasn't caught up on the adult side. One is there hasn't been providers on the adult side. And two, even if there are providers in certain areas, the clinic is not going to be set up in the same way ours is, where we have a social worker, we have a psychologist, we have nurses to call, and we're helping with scheduling. And there's not going to be parents there to help coordinate this for the patient. So the problem with transition is, or with what it has been, is patients turn 18 or they become adults. They then have to go to a different provider that they're not familiar with. They've been having their parents take care of all this stuff their whole lives. So now they have to schedule their appointment. They have to understand their insurance. They have to know how to do screening tests, how to schedule those appointments. There's a lot of appointments. Unfortunately, with sickle cell disease, as you get into those years, that's also when you start to develop more complications. And so there's a lot more on your plate. And so the idea behind transition is to better prepare those patients for the adult world. And so what we've done is, with the help of the Sickle Cell Disease Association of America and Dr. Wanda Witten-Sherney, we hired a nurse practitioner. Her name's Melanie Avella-Howell, and she has helped build a curriculum where we can teach patients everything they need to know about their disease, about insurance, about advocating for themselves. And we've worked very closely with one of the adult centers here, who is willing to take these patients and actually interested in taking these patients. So we're communicating with them and what do you need to know to take this patient. We communicate with the patient to know what do you want the adult provider to know. And it's sort of in its infancy right now, but already I think we're starting to see it pay dividends just through the education piece. And we're calling that clinic the Growth Clinic.
Oh, wow.
And it stands for Gaining Responsibility, Owning Wellness, Transitioning Healthcare.
Ooh, I love that.
We're very excited about it.
I love that. We're going to digress here, and he's always been good with words.
I was going to go there too.
Yeah.
It's a little known fact that Alex is a literature major in college.
That's right. English literature. I did a little sub-concentration in creative writing. I tell people I think that's the only reason I got any position I've had is that I wrote good essays and good letters, and people were impressed with that.
That's something that's always been so unique about you, but I think it's such a good skill to have. Anyways, sorry for that tangent there. But this transition clinic, certainly, in the landscape of sickle cell care in Detroit, is something that absolutely was missing, was in need of being built. So I'm so happy you've taken this on. You talked a little bit about Dr. Wanda Witten-Sherney. Certainly, while I was in clinic, it felt like that partnership with her was critically important to the health of sort of the community, the sickle cell community here in Detroit. Tell us a little bit about your working with her and how that's helped you, influenced you in your ability to be the best version of yourself as a sickle cell doctor.
Wanda Witten-Sherney is unique in her role in a certain sense, in that she worked in our clinic, in the hematology clinic. She's a pediatrician by training. Her father started the Sickle Cell Disease Association of America, and now she runs the Michigan chapter of the Sickle Cell Disease Association of America. So she is sort of this bridge point between the medical side and the community-based organization.
Yeah.
And so she has always been very integral to our clinic and has been an incredible mentor to me in just helping me, stay focused on the patients, because there are a lot of distractors. There's different people making different demands of you. You have to meet your RVUs. That goes into money for the practice and the hospital.
Yeah.
There's the broader hematology oncology clinic that we work within and we share resources with. And there's different priorities there. It's not always sickle cell disease first. She is such a warrior for warriors, in the sense that she will never stop fighting for warriors. And that's really inspiring to me, that even if I get frustrated with the system or the payers or whatever it is, I'm just going to keep going, because the patients deserve that, I think. And so I'm not going to stop.
Yeah, I think that's one of the key things for like these rising stars that are in our community, is partnering at that level with somebody in the community that can be that bridge point for you is probably the best thing you can do early in your career. Someone who really makes sure that your North Star is aligned with what it should be, which is the patients. We touched a little bit on your capsaicin study, but tell us where you ended up with that.
What capsaicin is, it's really the substance that's in hot peppers and it makes them spicy. And a long time ago, decades ago, they found that capsaicin actually targets a specific receptor in the body called TRPV1 or TRPV1. What TRPV1 is, it's a receptor that's on pain-sensing nerve fibers. And when something binds to TRPV1, it sends a pain signal up to your brain, and then you feel pain. Mm-hmm. And it's been used a lot for pain research. Mm-hmm. I mean, terms of triggering pain and seeing what are the downstream effects, what is the brain doing when you do this, and what are different inhibitors that we can use to block the effects of capsaicin. But some time ago, capsaicin started to be used as an actual therapy for pain too. The reason it's effective in that is it binds to this receptor, and it binds so strongly that it shuts off the function of that pain-sensing fiber, to put it very simply. And depending on the strength of the capsaicin, it shuts it down for a short period of time, or it can shut it down for a very long period of time.
That's like that sensation you get when you put icy hot on or something. It burns for a little bit, but then you like can't feel stuff.
Exactly. It's, we think of cold as this numbing thing, but capsaicin is the opposite. It provides this heat sensation, like it's the spicy pepper, right? But after a while, you just get a numb sensation. And during that research I was doing, after you stimulated my mind a little bit, one of the things I came across was a capsaicin patch. That's a high-dose capsaicin that is used for postherpetic neuralgia, diabetic neuropathy, other pain conditions. But at the same time I was doing that research, I was finding there was maybe a body of literature that's about 10 years old showing sickle cell patients get neuropathic pain also. And neuropathic pain basically means separate from a vaso-occlusive episode, the nerves just become sensitive. Over years and years of having vaso-occlusive episodes and vaso-occlusive pain, the nerves become so tense and so sensitive, they just start sending pain signals whenever, irrespective of whether sickling is happening or not. So even though we talk about pain in sickle cell disease as being the result of sickling, some pain is not the result of sickling in the immediate sense. And it can be very debilitating. It can affect quality of life.
Yeah.
And it's more of a chronic pain, right? And that's the type of pain that is not very well recognized by the medical community and the medical system. And in that sense, I don't want to say it can affect quality of life more, but in a very different way than hospitalization for a vaso-occlusive episode.
Right.
And so I thought this was a perfect thing to try for our sickle cell patients, because there had actually been evidence that TRPV1 or TRPV1 was very important to the development of chronic pain in sickle cell disease. And I just thought, why don't we just shut that part off and see how it does? So again, Dr. Z actually came up with the title of my pilot study, which was the SPICE trial, sickle cell pain intervention with capsaicin exposure. And we treated 10 patients with capsaicin over a period of 9 months. The patch that we used only goes on once every 3 months, and it has a durable effect that lasts that long. And we looked at the sensitivity. We used a tool called quantitative sensory testing, and we looked at the sensitivity of the skin where we treated, and the sensitivity went way down. And also, the majority of the patients said, we love this. It made my pain better. It didn't cause adverse effects in those 10 patients, which is a good thing. You have to start small. And patients have been asking me about it since then. So I've been trying to develop the next phase of it for funding. And actually, I recently got an internal grant to continue on with the next phase, which is going to be a bigger group of patients.
That's great. And we talk about this a lot, that people have repeated pain in an area and the nerves kind of, if you use a muscle all the time, they hypertrophy, you get more of them. And then you get this hyperalgesia where you're even more sensitive to pain because you've now got all of these nerves there, and you just get a light touch and you have pain. And we see that a lot in people with sickle cell.
That's one of the things that, quite frankly, results in so much judgment towards sickle cell patients or sickle cell warriors is they have what's called allodynia, where a light touch causes pain. It's because of this neuropathic element. So in the hospital, we've all heard from trainees who haven't been educated on sickle cell disease. I was one of those ones too. And they say, I barely touched the patient and they jumped out of their skin faking. You have to tell them, this is very real. There have been biopsies on mouse models of sickle cell and they show the nerves are hypertrophy, just like you said.
And now this is maybe a way to address that and hyperstimulate the nerves to make them kill themselves off and prune it and get to
a really good way to put it. What happens is those TRPV1 channels get upregulated. So there's more of them. They're more sensitive. So those nerve fibers become more sensitive. When you treat with capsaicin, it basically cleans the slate. Not to get too deep into the mechanism of it, but it prunes back those channels.
That's really exciting work, Alec. I'm excited to see where this goes. I think you have this therapy that's really the spicy stuff in peppers. It's really like a natural therapy that you can put on topically and potentially improve people's pain. I'm excited about it.
I'm excited about it too. And I think the underlying message is there's so many therapies out there that are used for pain in other disease states.
Yeah.
And it's very exciting. We have all these new therapies being developed for sickle cell disease, but we have so many available that we just have not studied. And they could be repurposed to good use for sickle cell disease too.
That's just fantastic.
I want to come back to this literature major stuff. And I know Alex has a few publications that are poetry. And I don't mean like they're great papers, like they're actually poetry. Tell me about that. How'd you get into that? And when do you do that? Is it like the spirit moves you? And
Yeah, I was an English major in college, and if I wasn't going to go into medicine, I probably was going to go into some form of writing, whether it was journalism or I always wanted to be an author. And it was maybe a little bit too serious of a potential plan that I was going to move out into the wilderness and just write.
Yeah.
And probably luckily I met my wife at the time and she was like, you're not doing that. But
She kept you from becoming a recluse?
yeah, exactly. But what I tell trainees when I round with them is we deal with a lot of heavy stuff. In our unit, we take care of kids with sickle cell disease who are in terrible pain. We take care of cancer patients.
Mhm.
We take care of really very sick kids. And it's easy to get into the routine and even become cynical sometimes about it. And it's a protective mechanism because we deal with some really heavy stuff. But what I tell trainees is every once in a while, you really have to take a deep dive and look at what we're dealing with here and consider what the patient is going through, because that's the only way you can avoid becoming completely cynical and then you become cold and callous
Right.
and whatever. And unfortunately, we all know people in the medical system that have become that. And,
Absolutely.
and patients will know that too, that you've seen those people. So it's sort of an outlet for me to just look at the non-scientific side. I do like to write poetry. I write a little bit of prose about medical things, about non-medical things. I've had a couple published poems about the medical side of things, and it just helps me reconnect with why I'm doing this.
I think if you write poems for warriors, then you're like a warrior poet.
I love that. I've never actually thought of that, but
That's pretty cool. The warrior poet who is actively trying to make things better in Detroit and working exceptionally hard for this community of sickle cell patients. Thank you for being a rising star.
thank you for having me. Thank you for getting me into the field of sickle cell disease. I really owe it all to you guys.
The field is better for it, and I can't think of anybody better to be pushing things forward here in Detroit.
Thanks, Alex. It was hard to leave Children's, but we knew we were leaving in good hands.
Maybe unprepared, but
Dr. Callahan, I think that this might be one of my favorite episodes.
Me too. Hometown boy done good.
Yeah, it's affirmation that things are looking up. It just fits the city of Detroit so beautifully. Comeback story, things are building up, things are getting better. There's reasons to believe in what's happening, and it's being driven by just a beautiful person.
A lot of great things going on. Great to hear, and always good to talk to Alex.
Yeah, so there you have it, Warriors. Please follow Dr. Alex Glaros. You can probably find him on Twitter, and certainly you can keep up with his publications on Google. Besides that, you can always follow me, Dr. Z, at Dr. Z Sickle Cell.
And me at Imagineer.
And of course, subscribe and follow Cheat Codes. And please do share this with somebody who you think could benefit from listening to it. And with that, Dr. C, I think it's time to go. Peace.